Hello, good morning. My name is Anisa Shrestha. I'm a student at Western Sydney University, and this is my student ID, and also it has my student number 221724333. Today, I'm going to talk about the case study of Mrs. Teresa Milo about embolic stroke. Today, I'll discuss the comprehensive nursing assessment and management of Mrs. Teresa Milo, a 68-year-old woman who has experienced an embolic stroke. Before that, I'm going to talk about the embolic stroke. An embolic stroke occurs when a blood clot or plaque fragment, commonly from the left atrium during atrial fibrillation, travels to the cerebral circulation, blocking an artery and depriving brain tissue of oxygen and glucose. The result is acute cerebral ischemia and neuronal death within a minute if perfusion is not restored. This presentation will address three key areas: the A2E assessment and how each step informed clinical decision making, for high priority nursing intervention with supporting rationales, and also nursing consideration for the medications, and which is alteplase, heparin, and metoprolol. This is the case introduction of Mrs. Milo, Miss Teresa Milo. Uh, and I'm going to start with the A2E assessment overview. Uh, the very first is the airway. Mrs. Teresa Milo airway is currently patient. However, her reduced level of consciousness, evidenced by a Glasgow Coma scale, scored 12 out of 15, and slurred speech increases her risk of aspiration. Impaired airway reflexes are common in acute stroke and may lead to hypoxia and aspiration pneumonia. Continuous airway observation, ensuring suction equipment is available, and escalating for intervention if the Glasgow Coma scale falls below 8 are essential nursing priorities to maintain oxygenation and prevent secondary brain injury. Talking about breathing, Mrs. Mild respiratory rate is 26 breaths per minute with swallow breathing pattern and oxygen saturation 95% while receiving 6 liters of oxygen per minute via Hudson mask. Tachypnea reflects a compensatory response to maintain adequate oxygen delivery to the ischemic brain tissue known as the penumbra. Supplemental oxygen is appropriate to sustain oxygen saturation above 94% and prevent further neuronal damage. However, oxygen therapy should be carefully titrated to avoid hypoxia, which may increase oxidative stress and worsen neurological outcomes. Assessment and collaboration with the medical team regarding safe antihypertensive titration with a target of below 185 over 110 millimeters of mercury if thrombolysis is planned. And talking about the disability, neurological assessment reveals left-sided weakness, facial drop, and aphasia. Serial observation using the National Institute of Health stroke scales and Glasgow Coma scales, which help to identify early neurological deterioration linked to cerebral edema or infect extension. Any reduction of 2 or more points in the Glasgow Coma scale score requires urgent review. Pupil reactivity and limb strength comparisons should be documented at each nursing round. And talking about the exposure, on exposure, Mrs. Milo is febrile with pitting edema in both feet and intravenous Hartmann solutions infusion at 20 milliliters per hour, maintaining normothermia and balanced by hydration. Support cerebral metabolism and perfusion. Overhydration should be avoided to prevent raised intracranial pressure. Now I'm going to talk about the summary of decision making. The A2E assessment highlights aspiration risks, suboptimal oxygenation, and neurological deficit management priorities include maintaining oxygens, optimizing perfusion, preventing complications, and activating the stroke team. And pathophysiologically, embolic contusion disrupts cerebral blood flow, creating an ischemic core surrounded by salvageable penumbra. Early intervention aims to prevent brain tissue and prevent secondary injury. I'm going to move to the next slide. Uh, Here I'm going to talk about the clinical decision making, high priority nursing interventions, and the another one is the frequent neurological observation. Perform Glasgow Coma scale and National Institute of Health stroke scale every 15 to 30 minutes initially. Frequent checks allow early recognition of neurological deterioration from cerebral edema or re-occlusion, enabling rapid escalation. Consistent neurological assessment ensures timely intervention, and minimizes the risk of irreversible cerebral damage. And the third one is the blood pressure management. If thrombolysis is planned, maintain blood pressure below 185 over 110 millimeters of mercury, and also below 180 over 105 millimeters of mercury after treatment. Gradual control is essential to maintain cerebral perfusion pressure while reducing the risk of hemorrhagic transformation. Ongoing blood pressure monitoring helps prevent secondary complications and promote cerebral recovery. And talking about the fourth one, the stroke team activations: notify the stroke nurse, neurologist, and physiotherapist and speech pathologist immediately. Evidence shows that coordinated nurse-led stroke pathways significantly improve door to needle time and overall patient outcomes. And early collaboration among multidisciplinary professionals ensures holistic care, optimizing neurological recovery and rehabilitation outcomes. Moving to the next slides. Uh, I'm going to talk about the medications and management of nursing considerations. The very first one is alteplase. Um, on the assessment, its indication is thrombolysis within 4.5 hours window. Assessment confirm stroke onset within 4.5 hour. Ensures it can exclude hemorrhage and that baseline coagulation test results are within normal limits. And also for administration, administer at alteplase at 0.9 milligram per kilograms IV, 10% bolus, remainder over 60 minutes. And side effects and monitoring: watch for intracranial hemorrhage and angioedema and bleeding at IV sites. Cease infusion, alert the stroke team if bleeding or deterioration occurs. And alteplase promotes cerebral perfusion by dissolving the embolus, reducing infarct size if administered promptly. And moving to next slide, and here I'm going to talk about the heparin infusions. On the assessment, check baseline, activated partial thromboplastin time, platelet count, and bleeding risks before initiations. And for the administration, begin continuous IV infusion according to activated partial thromboplastin time. Avoid administering other anticoagulants within 24 hours of alteplase to reduce bleeding risks. And talking about the monitoring and side effects: observed for bleeding, bruising, or heparin-induced thrombocytopenia. Daily platelet counts are required to detect early complications. And now I'm going to talk about the uh, metoprolol. Indication is atrial fibrillation rate control and blood pressure management. On the assessment, we don't if heart rate is below 60 beats per minute or if systolic blood pressure is below 100. And also for administration, administer 25 to 50 milligram of metoprolol twice as prescribed, and either orally or intravenously depending on the patient's conditions. And I'm going to talk about the monitoring and side effects of it. Observe for bradycardia, hypotension, bronchospasm, and fatigue. Monitor ECG regularly to detect conduction abnormalities. Metoprolol reduces ventricular rate in atrial uh, fibrillation, improving cardiac output and cerebral perfusion. Moving to the next slides. I'm going to talk about the conclusion. In summary, Mrs. Teresa Milo's embolic stroke resulting from atrial fibrillation related thrombus migration caused acute cerebral vessel occlusion and a neurological compromise. The A2E assessment framework enables systematic recognition of compromised function, while high priority interventions, oxygen therapy, neurological monitoring, blood pressure management, and team collaborations, targeted hypoxia and perfusion imbalance. Evidence-based administration of alteplase, heparin, and metoprolol further supported the restoration of cerebral blood flow, prevention of recurrent new emboli, and stabilization of hemodynamic status. Through timely, coordinated, and evidence-driven nursing care, nurses play a pivotal role in minimizing secondary brain injury and optimizing post-stroke recovery outcomes. Thank you for your attention and thank you for the time of listening. And, and this is the summary of key points which I already explained regarding that. And this is the reference that I have made so far. And thank you for your time. Thank you for listening.